joining us today. We have another Sagely Health webinar for you today. I'm Jeremy, CTO of Sagely Health, and I'm joined, as always, by Dr. Jason Sager. Jason, how are you?
Doing well. Thanks so much, Jeremy. Hello, everyone.
So today, we had a lot of interest in our topic of advanced diagnostics for cancer. So this is kind of part and parcel of everything we do. We want to get patients to the best treatments for them, and diagnostics are one of those paths. So why don't we just dive right in? Jason, could you talk just a little bit about the history of diagnostics? Like when someone's diagnosed with cancer, just the diagnosis itself is a diagnostic. And then kind of how traditionally has cancer been kind of defined and diagnosed, and kind of what's changed over time?
Yeah, diagnostics, just like everything else in cancer, is complex. It started off with looking at where's the cancer coming from. This comes from an organ, such as the colon. You've got colon cancer, or the breast. You've got breast cancer. And part of that was taking a piece of the tissue out and looking at it under the microscope. And so that's where it started. And that was done in the pathologist's office or lab. And they would take a look under the microscope and see breast cancer cells and say, oh, those look like breast cancer. Okay, we have breast cancer here. Or they'd look like colon cancer cells. Now, at some point, they began to look at stains and looking at proteins in these cells and say, well, these cells are producing proteins that otherwise might be found in the breast or the colon. And so we can really make sure that this is what it is. Now, all of that was done historically for many, many years. Much more recently, we've gone much deeper into understanding the diagnosis of cancer in terms of looking at the genes and other proteins and RNA to take a look at what actually is altered, what's making the cancer different from the rest of the cells of the body, or let's say the normal cells from the breast cancer or breast or colon. How are these changed? And by looking at this, we can try to figure out how to approach treating the cancer in a more specific, personalized, targeted, or immunotherapy approach. And so all of that now is sort of the modern era of diagnostics.
So just going back to your example with the staining, the idea that they might have taken so you're saying they might have taken like a biopsy from another part of the body and looked at that staining and said, oh, that protein's common to the breast. And is that where they're trying to find where the actual primary tumor is, where the cancer started, is what you mean?
That's right. That's
Okay.
right. And it's important to understand that because I think historically that's where treatments have evolved. If you have colon cancer, then you might get treated with FOLFOX, a chemotherapy regimen that's based on treating cancers of similar origins. If you have breast cancer, you may get tamoxifen. You may get other chemotherapies based on what they see in terms of that breast cancer cell. I think that breast cancer actually led some of that evolution of modern diagnostics, in that when they started to say, well, it's not just breast cancer cells. Some of those cells have estrogen receptors, some of them have progesterone receptors, and some of them have something called HER2 and HER2 receptors. And now all of a sudden you've got another layer, and that is sort of what we're talking about, the protein level of where we start to differentiate even amongst breast cancers. Well, there's very specific types of breast cancer. You may be HR, which is hormone receptor, or ER, estrogen receptor positive. You might be HER2 positive. And by virtue of that, we again start to treat patients differently. If you have estrogen receptor, you're going to get estrogen blockade, such as tamoxifen. If you have HER2 and not estrogen, you won't get that. You'll get something else, like Herceptin. And so really that treatment is personalized at a deeper level with the diagnostics.
And so is that done by taking, like you said, that tissue sample and looking that under a microscope to kind of see what's going on with it?
Absolutely. So, so from, at the initial point, when a patient gets diagnosed, a piece of tissue, usually by a biopsy, is being taken out of the area that is thought to be a tumor. They'll take a look to see, do these cells under the microscope look like tumor cells? And if so, where do they belong to? Where do they come from, that tissue of origin? And so so that's the first sort of step. there are other tests that they may want to do, such as genetic testing to see if there's a family relationship, and that's something different. Those are done on either saliva cells, like from the cheek, or from the blood. And there you're looking for perhaps genes that might cause cancer or predispose to cancer, but that's across family members, and that's something different.
So that's something you inherit from your parents, and you have that alteration in the DNA in every cell of your body.
Right.
That's just part of your DNA, and that might make you more susceptible to cancer.
Right. To getting developing cancer.
Right.
But that's not really sort of what we'll come back and talk about that separately if we haven't already. But but today we're focused on those tests that pertain to the actual cancer itself.
Okay. So then something happened kind of major with the being able to look at the DNA within kind of a tumor cell, when that biopsy is taken. And so it you can speak a little bit to this, but there was kind of a methodology that was created where they could test for a lot more things than they could previously, right?
Yeah. Once they realize that cancer is the result of genetic alterations, right? Those changes in the library of your cell that tells it what to do. And so once they realize that those letters were getting messed up, they said, well, let's start sequencing them. And at first they would do one at a time. And then they said, okay, well, let's focus on one gene at a time and take a look at the very special genes, the ones that are common to cancer, like KRAS, and we'll talk a lot about that. And at some point, they got much faster and much more broad about how they can do it. So they said, well, let's look at the 600 most common genes in cancer, and we'll call that next-gen sequencing. They said, let's look at the whole exome, everything that's being potentially coded. We'll call that exome sequencing, and so on. And so that really began the revolution that today is what we call modern diagnostics.
Okay. Yeah, I talk to a lot of patients and I will ask them, have you had tumor sequencing done? Have you had next-gen tumor sequencing done? And there's a lot of confusion around that. So I just love to run through it really quickly. So some people will say, yeah, I was tested, I have BRCA. And what they mean by that is what we talked about is they have a genetic alteration that they inherited. And so they have a susceptibility to developing cancer because if BRCA is altered, it doesn't repair damage as well, right?
Right.
So there's kind of that bucket of like what you inherited. And then there's some kind of cancer specific stuff where they might test for a few things. And so like, I think I've heard like, KRAS. Oh, I was definitely tested for KRAS. And I can kind of like, we might know what type of cancer they have or have some idea because they told us that, well, we didn't have a lot of tests done, but we had KRAS tested. And so there's stuff where they're doing single tests for certain gene mutations based off the origin of your cancer, whether that is a pancreatic cancer or a colon cancer or breast cancer, right? And then there's kind of we can test a lot more. And that's generally what the next gen part of next gen tumor sequencing means, the next generation of ability to test for a lot of things at once. Is that a good way to understand it?
Absolutely. And remember that like some of the genetic testing preceded the ability to look at 600 genes, next gen sequencing, right? So for example, lung cancer, they'll look for ALK, they'll look for EGFR. We started to understand the importance and the roles of those genes even before we had this sort of mass sequencing. They're still important. And so, but now at this point, there's really no reason to get individualized sequencing. If you actually test for 3 to 5 genes, it's the same cost as if you tested for 600. And so get the 600. And that way we'll know not only about those genes, but of course about all the other genes or many, many other genes that could be important in determining how patients get treated. Because again, our treatments have evolved too. And so now we have treatments today such as BRAF and KRAS and all of these that we never had before. And so while before they say, well, why bother testing them? There's nothing for us to do about them. But now there is, or there may be in the near future. And that's where we encourage patients to go and ask their doctor to at least get next-gen sequencing, right? And so we'll come back to sort of, who and that sort of thing.
So there are the NCCN, which publishes treatment guidelines in cancer, they must have some guidelines around diagnostics. And so that's kind of where this traditionally come is, oh, this, the colon cancer, here's the diagnostics you know, because if you know that, you go in the treatment. These are the treatments you would choose based off of that. So we're kind of hoping that everyone who doesn't have like a very easily operable cancer would get the tumor sequencing done, just because that's information to have now and in the future, right?
Well, yes and no. So NCCN really does focus on the standard care. And therefore, yes, they do include diagnostics, and they'll have for various cancer types where those diagnostics make a change in the standard treatment. And so you might have, 5 or 10 genes that they mention. Now, again, there are tests that test for those 5 or 10 genes. And so a doctor may say, well, I'll just get those. But what we're looking at is the world of all cancer therapies of the future that are coming down the pike today in terms of clinical trials. When we look across those, there's hundreds of genes that are being looked at and worked on. And even those that aren't yet being worked on, we know are important, and they can make a difference in how we discuss the risk with patients or other aspects. So that's where it's important to advocate for oneself as a cancer patient, or to advocate for a family member or a friend if they have cancer, and say, hey, doc, can I get next-gen tumor sequencing? And we've discussed this before, but it's a really important point.
Yeah, and it's been about a decade since the FDA approved, a little longer than a decade, the FDA approved next-gen tumor sequencing, and they've increased the population it applies to. I think it started with like metastatic, and then it kind of has applied a little bit from there. So that is in many cases covered by insurance, and almost, and so if it's relevant, it's covered by insurance usually. And so that's something where you can ask for, you may hope to get it. I think before we kind of go into some examples of like how this has made a difference in treatment, I'd love to just hear a little bit I hear about RNA testing and I hear about protein testing. And I know those are inter kind of locked with DNA, but could you talk a little bit about what those are and kind of where those are and kind of being regularly done?
Yeah. And let me just start with a challenge out of all of this, which is, how does a doctor who gets the results utilize those results, right? And again, on the DNA side, if a gene comes back and it's important, like EGFR, and now I can reach on the shelf and grab a medicine and prescribe it for the patient, then that's pretty easy to figure out. But there's a lot of complexities to these. And so many times the report will come back to the doctor and it doesn't really spell out what the doctor can do. Maybe there's a clinical trial, but maybe that doctor doesn't have that clinical trial. So what are they going to do with that patient? What do they tell them? So there's a lot of challenges as relates to the results of having this technology, which is wonderful. And it only gets more complex when we start to talk about all of the other things. So yes, the good news is it's covered by insurance many times. It's covered by Medicare, and for high risk disease that is expanding. And so ask for sure. What do you ask for? And in the sense that there's DNA, which is that original coding sort of library. That's the books, right? There's the RNA, which is what I would say is transcribed, right? This is someone copying the book down, saying, okay, well, this sentence means a lot. I got to make this protein, or I got to make that protein, right? So it's copying down single sentences and then sending off those single sentences as a message, maybe a text message, to the protein manufacturers of the cell. And then finally, you got the protein makers, the manufacturers, where they receive the message and then actually create the protein. And once they create the protein, that protein then starts to do the job that it's intended to do. So cancer, we talked about a few proteins such as estrogen receptor or HER2 that have been tested right from the very beginning. And they've been tested one at a time also, or maybe 3 at a time. Now we can test for all of the genes, the whole exome. We can test for all of the RNA, called RNA-seq, and we can test the entire exome for that as well. And then finally, we can start to test for multiple proteins at the same time through a process called mass spec. And we can test for hundreds of proteins at the same time. And so what we're recommending for cancer patients is to get the full package. to get the DNA, next gen sequencing, the RNA, and there's a company that does both together called Boston Gene that we recommend. And then finally, the protein, and the company there we're recommending is called mProbe. And then they offer this mass spec protein for hundreds of protein at the same time. There are a few others that do it as well for each of those three, but those are the folks that we're using most commonly.
Yeah, I want to just point out that, when these are done, they are sent off usually to a third party company. There are some cancer centers, I believe Memorial Sloan Kettering has kind of their own panel that they do of tumor sequencing. But you hear names like Foundation Medicine, Tempus, Caris. And these reports that they produce are complex, and they're definitely made to kind of feel a little simple in the beginning. They'll kind of like point out like, oh, here are the, things that we know in your cancer type that are always relevant. And then it kind of goes from there. And there's like these long lists of things. So I just say to people, like, it can be very hard to interpret this, but you totally have the right to get this report yourself. And so it will, if your doctor orders it, that report will go to your doctor, but you can contact the company and identify yourself. They'll probably go through some process, and you can also get a copy of that to share and analyze however you want. And that's something we do a lot of helping people with, is kind of, what do you do with this results? Because I want to just underline what you said, which is, if the doctor that you're being seen by does not have a clinical trial at all, they're not going to have a clinical trial targeting one of these alterations in your genetics and in your tumor, and therefore there's no going to action to be taken. So in some cases, this information you need to kind of widen the scope of where you take this, and possibly get yourself, work with Sager Health, of course, but like get yourself to an academic medical center. And in somewhere that's more likely for trials to be going on. And you can also use the terms you see as searches online to kind of find trials and things. So I think that you may need to take action. I just want to underline that you may need to take more action, even if you get the test done. And we've seen that a lot.
Yeah. And, again, good doctors, they'll share the report with the patient. Now, oftentimes the patient has to ask for it. Hey, doc, did we ever get the results of that testing that we did? We're actually seeing quite a resistance to ordering the mProbe test, which is interesting. It's brand new. Yeah. And again, it takes time to get this through the system. So we've found doctors who are more willing to sign off on these things. There's a doctor named Tony Magliocco in Canada who is authorized to sign off on these things. And he's seeing patients and helping patients to get this mProbe test. There are others. And again, we make sure that patients are connected and get what we believe is the best possible diagnostic set, so that we can then match them up with the best possible treatments.
Yeah, and I want to jump ahead to a question we got from someone who's attending today, who asked about does his testing meet Medicare requirements? And and they point out that most cancers are in older people, and so I think it's a valid question of like where we are in insurance coverage, both the kind of the Medicare level, but also private insurance.
Yeah, and so for the next gen sequencing, it is very much covered by Medicare. Again, it's about 10 years old or so, maybe even 15 years old, the original ones. And so, there's been a long, lengthy process. And a lot of the companies also have a policy where if there is an out-of-patient cost, they will forgive that portion of the test. And so patients can, whether they get it from Tempus or Caris or Boston Gene or Foundation Medicine, they can expect that they won't have to pay out of pocket for those tests. As long as they fit within those categories, then no cost. The mProbe test, again, is a lot newer. So they haven't gotten it to the point. It is blessed by the by the FDA. So the FDA is certified that this is a test by which they have CLIA certification. Patient decisions about patient medicines can be made based on the results of this test. So they pass a high standard to meet that qualifications. But Medicare, which is governed by a group called CMS, hasn't yet sort of blessed the payment for those services, right? That diagnostic test. And so over time that will come. But in the meantime, patients will need to pay or will expect to pay something out of pocket. And currently that's measured in like $1,000 or so. And so that's something that, over time I expect to change. And it may not be available for every cancer patient, but at least get the next gen sequencing, get the RNA-seq by going through Boston Gene, and then when possible, and get the M-probe test.
So a question I would have, and it has come up. What if I don't have tumor material? Like a biopsy was done, that was completely used by the pathology department for diagnosis purposes, and I don't have any tissue to offer to have tested.
Yeah, and so there's another new diagnostics that's based on the same principle as next gen sequencing, but instead of doing it on the tumor, they're actually looking at DNA that's shed from the tumor, and it's shed from the tumor into the blood. So they get a blood sample, and this is called a liquid tumor biopsy. So if the doctor says, "Oh, but you don't have any tumor tissue, but otherwise I would get this next gen sequencing that you're asking for," then you say, "Hey doc, how about a liquid tumor biopsy?" And that's something that can be done again by many of these same groups, such as Foundation Medicine or Tempus or Caris, and that's a reliable test as well.
Do people ever get a secondary biopsy just for this purpose?
Well, the fact is that both of them can be quite complementary, because if you imagine you get a biopsy with a needle going into one location of the tumor,
Right.
that tumor may have other changes in other parts. So the liquid tumor biopsy is sort of nice because it's really surveying the entire sort of neighborhood of cancer cells, right? And so you don't just look at a single address to see who lives there. You're looking at the entire neighborhood, and you may see some variances and know, okay, well, we need to treat with a specific medicine in order to capture the entirety of the cancer and not just from a single particular part. So there are some advantages to doing both.
Gotcha. So I want to ask about kind of the reasons for doing this, because it sounds like we're asking patients be proactive, ask about these things, do it, chase down the report, maybe we're asking for quite a bit of effort from them. And I think, as you and I know, proactive patients generally get better outcomes. And so can you talk a little bit about what's to gain here by putting in this effort?
Yeah. And so, I think there's a few examples that we can talk about in terms of what's to gain. And again, we come back to the idea of that personalization of cancer treatment, which everyone knows, and no one really likes the idea of chemotherapy. It's, the traditional old-fashioned sort of, nitrogen mustard sort of chemotherapy where it makes you feel really, really sick, and you can, stave off the tumor growth from some period of time. But over time, usually it has to stop because the patient feels so sick, and then the cancer just starts to grow again, or the cancer figures out how to grow around it. And so these are much more precision guided, heat seeking sort of personalized treatments that can really try to damage the tumor without harming the patient as much. They still have side effects, most of them, but at least they're hitting the tumor a lot harder. And so by virtue of that, patients are doing better. They're living longer with higher quality of life. So the key to unlocking that door is this advanced diagnostics that we're talking about. And for example, we mentioned HER2. Classically, that was always looked in breast cancer because 25% of patients will have HER2 being amplified. We now know that even high expression of the protein matters, or even low expression of the protein can be targeted. And so now it's up to 60 or 80% of patients who will be able to utilize therapies, treatments that they would never have had access to before. But what's amazing that HER2 is actually present at some lower percentage across almost every cancer type. So it may only be 2% of, of pancreatic cancer, or maybe it's 10% of gastric cancer. But the fact is, for those patients, and again, like gastric cancer, pancreatic, those are high risk cancers. If you have that and you have the HER2 expressed or the HER2 amplified, then you've got another path towards treatment, and those patients do much better. And I'm talking about like years better than those who either don't have that gene or don't get tested, right? And so that's where the testing can really make a difference. And if it's not HER2, it could be another gene. Right now they're looking at KRAS, and they have new inhibitors against KRAS that they've never had before, and specific variants, G12D, G12C. There's all of these specific drugs coming out. And it's helpful to know so that we know which patients should be tried on these various targeted treatments. And that's a lot of what we do. We understand, we unlock the door, we understand what's there, and then we select treatments that we think are best aimed to attack those cancer cells. Much like EGFR, ALK in lung cancer is being done today. They're up to like their fourth generation of EGFR inhibitors. And just the results are amazing. People are living for years and years and years with metastatic cancer, where before it was weeks to months. And so over time, we're able to really do much better for patients. And everyone, again, cancer is a disease of genetic origin. So everyone has something. We just have to figure out what that is and can we target it specifically with a treatment.
Yeah, I would just say I think that it's important to understand that when we talk about like protein expression, like whatever's going on with your tumor, when scientists and doctors have been able to target that in a personalized way, the results have been fantastic. Just the improvement in outcomes for patients. And they've often hit really large swaths of patients, like you said, like most breast cancer, like 25% of breast cancer has HER2. And so there was a big win there. And then you apply it to other places, but like the approvals that we're seeing in cancer drugs now are about personalized treatments. They are generally, that's where the wins are, when you know what you're targeting, you know what's driving that tumor's growth, and you have something to kind of hold on to when you think about what drug you want to use, right?
Right. And and in the sense that, you used to be, years ago, if you had a 5% of patients would benefit, woohoo, that'd be great, right? 10%, amazing. 20% would be like almost unheard of. Now, like if a drug doesn't create 20% tumor shrinkage, significant tumor shrinkage in 20% or more of the patients, they don't even the drug, no, not that interesting. No one's that interested. Now we're seeing 40%, 50%. PARP inhibitors in BRCA deficiency is 60% response rates. And again, those last for months, if not years. And so we are doing much better, but patients have to still know and advocate, because unfortunately the standard is still that very much unselected off-the-shelf chemotherapy or chemotherapy regimen like 5-FU, Taxotere, docetaxel, adriamycin. I mean, there's a dozen of them, right, or more. But these are the ones that are unselected and generally make patients feel sick. Some of them do respond, and their tumors will either shrink so they can get surgery. But over time, they generally wear patients out. And, we have a patient living on Enhertu, which is an antibody drug conjugate we reviewed, I think, in our last
Yeah.
webinar, against the HER2 protein on the cell surface. And when we start to look at some of these cell surface proteins through a test like mProbe, we can select these antibody drug conjugates. We have a patient who would have been gone years ago without this, and now is basically living on the medicine without any evidence of disease. Literally, the last scan showed nothing, no cancer detectable. And this is something that was never seen before. So it's exciting.
It is exciting, and unfortunately, it's very uneven from what I can tell when I talk to people. And I think there are many people we meet who should have had these tests done for many good reasons, and they're not done. And we can help them do that. And it's something where we wish people didn't have to be as proactive, but they do. And we wouldn't be talking about this if it didn't really make a big difference.
Yeah.
I wanted to ask about, so we talked a little bit about asking for these tests. I mean, could you talk a little bit about some objections one might hear if I said to my doctor, hey doctor, I heard about this thing called next gen tumor sequencing. I'd really like to get that done. I just want to know what that might show for me. Could we get that done? What are some objections that you've heard in the past from doctors, and kind of could talk about why they're not, could become overcome?
Yeah. I mean, I think the first one that we commonly hear is that, well, that doesn't pertain to your cancer, right? That that your cancer doesn't have an NCCN recommendation to get one. I wouldn't know what to do with the results. They may not say that, but in the sense that there's no standard therapy that I can reach for. However, what they're not telling you is, there's lots of clinical trials, and so again, that's where patients need to push back and say, oh, I understand that. I'm looking at this for the future after, if I have a high risk, let's say I have a high risk tumor, uh, we might get to a point where there are no more standard therapies. And I'd like to know what's out there. Or, hey, I understand that there's HER2 and that HER2 is at some percentage in all tumors. I'd like to take a look to see if I have that. And while we're doing that, look for lots of them, right? Do the next gen sequencing. So there's ways that we instruct patients to sort of get this done. I'll just say the other common one that we hear, just for patients to know, is sure, but let's get that later. Once the tumor comes back, right now we've got standard therapies. Let's get it later. The problem is that later, that this test takes usually 3 to 4 weeks to perform. Sometimes it's a little less, sometimes it's a little more, depending upon how fast the tumor gets to the company. But the fact is that once the tumor comes back, no one's waiting for those results. So the best way to do it is from the beginning, right? And some doctors will say, well, you might have new mutations or different mutations. Well, generally mutations add on. So let's find the ones that are now. We can do it again later. That's fine. But at least let's find out the ones that are there now so that we can plan for later, just in case it comes back. So that when it does come back, you've got those answers in your hand and ready to go. And you don't have to wait a month because no one's doing that. They're going to start another test, another treatment, and then chemo treatment. And then they'll say, oh, well, let's wait for the next time, kind of thing, right? And it goes on from there. So that's another one that we commonly hear.
Yeah, and I would just point out that, we at Sager Health, we process all the clinical trials for cancer. And this week, there are 200 new ones for us to evaluate. And so I guarantee many of those, if not most of those, are targeting some genetic mutations, and they did not exist yesterday, and they exist today. So I think that the whole field is moving, and so having this in hand and being ready with it just makes sense. I just want to underline that for the idea of timing. Like, now is the right time. Later might also be the right time. Like, if you really want to retest later, fine. But now is always the right time to do it, for all the reasons we're talking about. So I want to switch gears just a little bit for a second to talk, when we talk about doing diagnostics, we talked a little bit about kind of advanced imaging. And I just want to spend a little bit of time, if you could just talk a little bit about what are the kind of the more advanced sides on kind of the scans and those sorts of things that can be helpful for patients.
Yeah. And so, again, this revolution in terms of diagnostics and the advanced diagnostics have not only helped with treatment, but they're also helping with imaging, right? And detecting, let's say you have a protein target that you're looking at. Is that in every cancer cell? Is it all over the body, or is it in certain places? And so, as an example, everyone knows the PSA test for prostate cancer, the prostate-specific antigen. And so men will have this monitored, and if it starts to go up, this may be a warning sign. It's a tumor marker that there are cells or proteins where they're not supposed to be. You're not supposed to have PSA circulating around the blood, so it must be getting there somehow. There may be some cancer cells. We'll take a look. Going beyond that, they figured out that you could actually use antibodies against these proteins, just the way you do for treatment, but you can use them with a imaging agent attached to it. So now they've got PSMA scans where they inject you with a small amount of this, and then they image you, and they can see exactly where the prostate cancer has spread, if it has. And then they can actually use a different treatment with a different radioisotope on it that then kills those cells. And so there's a whole staged approach that's coming down the pike for some of these proteins, where first they're using them as advanced imaging, and you can get your PSMA scan, but then you can also get your PSMA treatment in prostate cancer if you're positive. And so that's something that is happening today. And it's just one of the very exciting things that's sort of evolving in cancer care.
Yeah, that's great. It made me think of something that's kind of related. Someone asked about the insurance coverage. I want to ask about scans. People regularly get scans to kind of monitor the growth of their tumors. And so insurance will often cover, like, as I understand it, like they'll cover like, oh, you can't have your scan for another month because we won't cover another one for another month, right? So that's kind of how I operate. How do clinical trials handle that? Do they handle that differently?
Yeah, the vast majority of the time, the clinical trial will pay for the scans that they're looking for on trial. And so, if they're, especially if they're not in alignment with sort of the usual timing. So, as you said, an insurance company may say you can get a scan every 6 weeks or every 8 weeks, sometimes even longer. Well, maybe the sponsor of the trial wants to get a scan after the first 6 weeks that they're on, and maybe again after another 6 or 8 weeks, and that's just not the usual sort of cadence that would happen. You might doctors say, come back in 3 months. Okay, well, no. And so they'll pay for scans that are not covered automatically. They'll also potentially cover scans that the doctor thinks could be really helpful for the patient or for the company to learn more about the cancer. So there's a special diagnostic test scan called the PET CT scan. And it's not for all, but it is for most. And the PET part of it is that you're using a little bit of radioactivity in glucose to look at the glucose metabolism by the cancer. And cancer metabolizes faster than most other tissues in the body. And so they can use this special test to take a look and kind of super detect any cancer that may be having spread. That's different than a regular CT scan. The regular CT scan is generally a bit less sensitive. So the CT scan may be covered, but on the clinical trial, you may be getting a PET CT. And so there are unique aspects to these where patients can get, by virtue of participating in trials, better advanced diagnostics. Some of them have the sequencing and the other protein testing. Some of them offer some of this advanced imaging.
That's great. We've covered a lot of it. I just want to ask, like, is there anything you want to say about kind of the direction of kind of diagnostics in cancer overall? I mean, because we've covered kind of what I think is kind of the traditional, the kind of beginning to be adopted in a wide way, which is the next gen sequencing. I'd say the RNA and the protein stuff is a little bit more advanced. I mean, do you feel like these are things that everyone's going to get at some point? I'd just be curious to hear your thoughts.
Yes, but the problem is that the number of years that might take to happen naturally, I think, is quite large, like 20 years or 40 years. I want to get these for our patients today. The technology is known, and I get it. It's complex, right? You want to make the FDA and the government, they want to make sure that that test is the very best test for patients. That's super reliable. Okay, and if you make any changes to that test, you've got to kind of go through all the certification, even if the technology is the same. But I don't. If I have an iPhone 11 and I go to an iPhone 12, it's pretty much the same. A little different, but it's going to work, right? And so, in that sense, it's hard, and I get that, but it does tend to slow things down. And what I'd say the biggest sort of gap today is in that protein testing, where now there's the ability for the very first time to do hundreds of proteins at one time with one little piece of tumor. And so it doesn't use a whole lot. And to me, we are hearing most doctors say, that's not a standard test. That's not going to be covered. I'm not going to order that. None of the companies are asking for it. And all of that's true. However, it is the best test for us in determining what priority to put the therapies in. So saying, well, you got a ton of this protein, Nectin-4. Let's try a Nectin-4 antibody drug conjugate. You've got a little bit of another protein, TROP2. Let's try a TROP2 antibody drug conjugate. You don't have any HER2. We're not going to go down that path. And so to us, it makes sense. And yet it's understandable the system's just not there yet.
So let's talk. We've talked about a gold standard, and I think you mentioned it earlier. This idea of Boston Gene is a great company because they're doing DNA and RNA testing at the same time, right. And then there's mProbe that's doing the protein testing. And just to kind of go through it again because it is confusing, is this idea that you may have alterations in your DNA. And those alterations in the DNA can often result in an RNA taking a message and creating a protein that's ineffective or incomplete or something like that. But it doesn't necessarily mean it exactly happens that way. So you've got a clue that something major is happening here with an alteration, and so there could be, in reality, when you get to that protein on the surface, that's what's really there. I mean, as far as like what we see in the test. So like you said, you could have a bunch of different alterations, but there's one that's actually really resulting in a lot of protein on the surface, and you're saying that's what could be more targeted. So you really are. It's not that the protein test is unlocking some new option. It's really more about prioritizing what options are available, right?
Yep. Yep. And there's a lot of details, and they all matter, right? If you're going to go buy a house, you want to take a look at that house before you buy it, right? You want to know, how many bedrooms does it have? How many bathrooms does it have? Now, maybe for you, making sure that it has several bathrooms is really important. Maybe for another person, having more bedrooms is more important. How about windows? How about a garage? Air conditioning, heating, right? I mean, like, all of these things matter.
Yeah.
And yet you don't get to kind of pick them all. You got to kind of find out, well, what's that cancer location? What's that address? What's that house look like? So I can now say, there's an open window there that I can throw a baseball through and hit something, and we can attack that cancer. And we've got to approach it like that. We've got to get that holistic picture. And again, there's things that we can't do today that we'll be able to do tomorrow. And once that's there, it'll grow. But already it's pretty sizable, and we are succeeding in ways that we've never succeeded before by virtue of getting that very explicit, detailed picture of the cancer.
Yeah, I like this metaphor. So just extend that metaphor for a second. If you say that choosing a cancer treatment is like choosing a house, what we're kind of saying is, in the past, you didn't get to see the house. You just had to choose. And now you get to see the house, and it used to be like a really terrible drawing of the house. And now it's kind of like way more detailed about what's actually house. You see the walls, you see the windows. Like, we're just like, there's more data. And in this case, more data is good, in the sense of being able to make choices. So, okay, so we've talked about some huge advances that have happened in kind of the science. We did have one question. It's a little peripheral, but I think it's really interesting. I think we can just spend just a couple minutes on it, and we could probably do a whole webinar on this. But one of our patients reached out and said, will the use of AI, artificial intelligence, help us fast track identification and more targeted treatment, and kind of what clinical trials that we run? And so, AI is something that, we kind of work with a little bit in different ways, and is affecting the whole field. Because I'd love to hear kind of your thoughts on kind of what how is AI is being employed now, and what you kind of imagine in the future.
Yeah. First of all, let me just say that, really excited about the advances that are coming out from AI. I understand and, know that a lot of people are fearful of it and have written how it could damage things, but we're looking at AI as a way of helping, as a tool that can really help us to do better across the board. And it's already being used in several different ways in cancer treatments. It's being used right from the very beginning to design those treatments. Now AI can understand how proteins are folding so that we can understand how to design a chemical structure, also helped by AI, to design a structure that will fit into that pocket and block it from working for specific proteins that we're targeting. Companies are also using it in terms of understanding which proteins to go and assess once they have a drug. And they're using AI for that because they're looking at cells and cancer types that are responding to that may be in the petri dish. And so how does that relate to humans? Well, they'll look at hundreds and hundreds of these things and try to pick out what DNA, what genes to look at, or proteins. We're also seeing it being used today in helping us. It doesn't replace the expert today, but it enables us to get a lot more information in about what's going on out in the world. And so we're using it on a daily basis. If someone publishes an article, we're likely getting that article into our hands. And there's so many publications, there's so much information. It's overwhelming. You'd have to have a team of hundreds of thousands of people to look at this. But AI is helping us to digest that, tell us, hey, these are the really important things. This has really good information in it. You should take a look at this one. And so we do. And then we put it into our system. It's not to the point where it can select sort of treatments on its own, but it can help patients to sort of get apprised and get information so that they're better prepared to walk into their doctor's offices. And so we're helping to do that with patients through some of the AI tools that exist today.
Yeah, I would just say that, patients should kind of try out AI for better understandings of their cancer and treatment options and those sorts of things. What it can do a wonderful job with the learning large language models that we have now is just you can interrogate it. You can get an answer. Like, right, it used to be you Google, well, it used to be you had to read books, but then you kind of Google things and you find it and you're like, well, I don't understand that. There's nothing you can do. With AI, you can then ask a further question. You can ask for a clarification. You can state your understanding and have asked if that's correct. And I mean, that's something that's been really helpful just across the board. But yeah, I mean, it's interesting that the entire way up the tech stack, like everything from the early science, the basic science work to the actual treatment, to even running the clinics themselves, will be affected by AI in so many different ways.
Yeah. And again, it's really new still. Medicine is probably one of the slowest areas to change. And so we'll see how long it takes to really get integrated. But again, there's a lot of predecessors, right? The electronic medical records are already here. And so, we do expect that it will help. And again, very excited about the tools and how fast they're advancing so that we can do better and better for each other, for humans, for patients, and utilizing that to help treat cancer is what we're here to do.
Well, I think that's been great. Is there anything else you would add on the topic of advanced diagnostics that we haven't kind of dived into?
No, I'd say that's a good place. There's a lot of information here. And again, we try to simplify things and make it straightforward. If you're a cancer patient, make sure you ask your doctor, can I get next-gen sequencing? Can I get Boston Gene because they have whole exome RNA-seq? And can I get mProbe, the mass spec protein test, to look at hundreds of proteins in that cancer? Those are the questions that we would have every cancer patient ask their doctor today. And if their doctor doesn't look like they know what they're talking about, come to us and we'll help you.
It's a good place to wrap up. So it's Sagery Health, www.sageryhealth.com. Just reach out. We'd be happy to talk and see how we could help. And yeah, thank you for the time today, Jason. This has been great.
Thank you, Jeremy. Thank you, everyone. Take care. Best wishes.